Explaining pain to cancer patients and cancer survivors. Here we briefly inform you about key aspects on how explaining pain differs in those having cancer-related pain to non-cancer related pain. One key aspect to explore among cancer patients and cancer survivors is where the pain is connected to the initial cancer diagnosis, because some patients have the experience that pain was one of the reasons why they consulted the physician and how they eventually found out they had cancer. This creates a powerful connection in the brain of these patients between pain and the life-threatening illness of cancer. And this creates a new dimension for pain to those patients, one that should be addressed first in the explained pain phase, but also during subsequent treatment, more active treatment in the cancer survivorship phase. Another key difference between non-specific pain patients and cancer and post-cancer pain patients is that there are many factors in the treatment of cancer that can contribute to damage, objective damage of the nervous system, either the peripheral and the central nervous system, but most often the peripheral nervous system. As you can see from this slide, many treatment factors relate to the development of neuropathic pain, often peripheral neuropathic pain among cancer patients, and this continues to be a debilitating part of the illness in the cancer survivorship phase. Of course, the tumor itself has many neurotrophic and cytokines that are produced in the surroundings of the tumor itself that sensitize the nerve endings surrounding the tumor, but the many invasive but often life-saving treatments like surgery, radiation therapy, and chemotherapy often have some side effects, including damage to the peripheral nerves. This creates neuropathic pain, obviously, which is very common among cancer patients and cancer survivors, and much more common than in other pain populations. Another treatment factor related to pain in cancer patients and especially in the cancer survivors is the use of aromatase inhibitor therapy. Aromatase inhibitor therapy is an effective treatment for hormone-sensitive types of cancer to prevent cancer reoccurrence and also to treat certain types of cancers which are hormone sensitive. But one of the negative side effects of aromatase inhibitor therapy is that they also activate one of the ion channels, as you can see on this figure, one of these ion channels in the C fiber endings. The transient receptor potential ankyrin type 1 channels in the nociceptors are activated due to aromatase inhibitor therapy, and this activation of this ion channel then triggers the release of sensory neuropeptides, creating some type of low-grade neuroinflammatory and local neuroinflammatory response, creating generalized but peripheral sensitization. So the peripheral nerve endings of these C fibers actually become sensitized, creating musculoskeletal pain that cannot be explained by any other reason. And this is a debilitating side effect, but again, explaining this to patients can create some reassurance to these patients because, of course, the importance of the aromatase inhibitor therapy in the prevention and the treatment of cancer and cancer recurrence is so important that one should not stop this type of treatment because of the side effects. The close link between many of the the cancer treatments and the occurrence of pain in breast cancer patients and breast cancer survivors was recently confirmed in a meta-analysis conducted by Leysen, and this slide summarizes the main findings, further confirming the role of radiotherapy, chemotherapy, hormone therapy, but also, of course, in the breast cancer patients, confirming the role of lymphedema and axillary lymph node dissection, which of course are closely connected to one another. Of course, meta-analyses are limited to the available scientific literature in that area. And more recent work by Anne de Groef from Leuven showed, and again, that central sensitization takes a part in the pain experience of many breast cancer survivors as well. From her work, it was even shown that central sensitization explained up to 40% of the variance in upper limb function, so not only pain but also upper limb function in patients who were 1.5 years following breast cancer surgery. And as you can see from this slide, central sensitization was even more important in explaining the variance of upper limb function than other more obvious factors like shoulder range of motion and hand grip strength, even though those factors were also contributing to the variance. So central sensitization can be a factor of importance in these patients, although it's not present in all patients. Leysen did some nice pain phenotyping work in breast cancer survivors, and don't focus on the details of this pie graph, but there are two main messages that you can take from this pie graph. One is that pain is very complex among cancer survivors and breast cancer survivors in particular, and that there are many different types of pain subtypes within that population. Another key factor is that you have a lot of mixed type of pain, so a mixture between nociplastic, nociceptive and neuropathic types of pain, and in general up to 40%, 44% of the patients can be labeled as at least partly nociplastic pain, implying that central sensitization contributes to the pain experience in those patients. Depending on the type of pain, either nociceptive, dominant, neuropathic, dominant, nociplastic, or mixed type of pain, the type of communication that you give to these patients and the type of and the content of the explained pain part of the treatment differs substantially. And this makes sense, and this is one of the key reasons why one should actually do and perform some this type of pain phenotyping at the beginning of any treatment program for these patients. For instance, if neuropathic pain is obvious, then one should explain the catastrophic name, which is neuropathic pain, and explain, of course, the mechanisms explaining neuropathic pain, including central sensitization. Central sensitization is also something you can explain in patients having nociplastic pain, and if relevant, also in mixed type of pain, but of course it's not something you will explain to patients having a primary nociceptive pain, for instance, in early phases following surgery for cancer treatment. Another important factor to many patients, if not all cancer patients, is social support. And one of the key factors contributing to social support is support from their partner. However, in the cancer survivorship phase, that support can become a bit lower because, of course, at that point in time, there has already been quite a large amount of time that has passed away where the partner has provided a lot of social support. And when the oncologist then explains to the patient and the partner that the patient is cancer-free, then long-term pain and fatigue experiences can result in a partner responding to the pain and fatigue with irritation, anger, or frustration. If this is the case, then social support drops, and this further aggravates the pain, and this is not helpful for the patient at all. In general, social support is also important for long-term prognosis and even survival rates for cancer patients, so it's not only of importance to pain and fatigue symptoms in those patients. If social support is not optimal in patients, then it's important to address it. We can address it also during the explain pain, and this can be done by trying to include the partner in the treatment, in the education phase, by asking the patient to bring their partner to the explain pain sessions, or if this is not feasible, asking the partner to read some information leaflets or study some online pain education material. And this can assist the partner in applying healthy coping strategies. The final issue I want to share with you is perceived injustice. There are some fascinating data coming up from Leysen's PhD on pain in breast cancer survivors, showing the important role of perceived injustice as a key factor in contributing to the pain experience in breast cancer survivors. Perceived injustice is the patient's perceptions of blame and unfairness, not only in relation to having developed the cancer process, but also in relation to still suffering from pain symptoms long after having survived the cancer illness itself, but also in relation to cancer. The example on the slide of somebody who never smoked but eventually was diagnosed with lung cancer creates in itself perceived injustice. So screen for it and try to address it when explaining pain to cancer patients and cancer survivors. If you want to learn more about explaining pain following cancer and to cancer patients, please check out the masterclass paper, which is now available from the Brazilian Journal of Physical Therapy.